and we are excited to get started. So I'm going to just dive in so we can get to as many questions as we can. What is the biggest risk of an excision? This is from one of our followers here on one of the Occipital Neuralgia Facebook groups. And the simple, and there's no one answer to that question. There are any number of risks with any procedure, whether it's RFA, medicine, or surgery. And when you're talking about surgery, you're really not talking about excision, because to excise something means to cut out. So if you had a cyst on your face, you would excise that cyst. You want to remove upstream from where it's, let's say, frayed. If you're think of a nerve as like an electrical wire, to use that analogy. And so one of the common side effects from a nerve transection is that you have numbness in that nerve distribution. Okay, one of the criteria for deciding whether or not to cut a nerve, in my opinion, and in my experience in my hands, is which nerve we're talking about. Because if you're talking about, for example, the greater occipital nerve, then you are likely to experience a fair bit of numbness on that side. Let's say you're taking or transecting the greater occipital nerve on the right side. You will have a pretty large area of right-sided occipital numbness on a permanent basis, okay, because that nerve has a large nerve territory, as its name suggests. It's the greatest of the occipital nerve, the largest, has the largest nerve distribution. If you're talking about the right third, which is also known as the right least occipital nerve, then that nerve has a very small sensory distribution. It's very small, and in addition, if you have a random area of skin, and there are 3 nerves that go to that area of skin, then if you cut one of them, post-surgically, if you touch that area of skin, you will actually perceive pretty much that that area feels normal to you. Why? Well, because you still have 2 nerves that are mediating sensation to that area, and you could probably do just fine with 1 nerve, but the fact of the matter is, the fact that you don't know which of those remaining 3 nerves is mediating that sensation suggests that the sensation will be normal, and therefore it won't really practically matter. And so one reason I have a lower threshold in my hands, for example, for cutting the 3rd occipital nerve is because there are other nerves that supply sensation to the skin in that same area. So very often when you cut the 3rd occipital nerve as a patient, you never really realize that anything has been cut after a few weeks or a few months, when everything has healed and all those nerves that are remaining come back online. So that's one of the risks, if you will, or side effects of an excision. Another risk is that you have a neuroma that forms. Now, a neuroma is an actual histologic designation. What does that mean? Well, if you cut a neuroma out and send it to the pathologist, and they slice it up into these little microscopic pieces and stain it like they do for any tissue, whether it's breast tissue or nerve tissue or liver tissue, and look at it under their microscope, they will see 2 characteristics that will define a neuroma. One is regenerating neurons. Okay, so the little nerve fibers and nerve cells in there are trying to regrow. And 2, you're going to find scar tissue. That is the definition of a neuroma. So you can always get a neuroma whenever you manipulate a nerve, okay, or when you cut the nerve. Now, I would say that you would have a slightly higher risk for a neuroma forming if you cut a nerve as opposed to just manipulate it, because that nerve will for sure try to regrow if you cut it. However, if you know how to manage that nerve, and you can't just cut it and just leave it, especially under the skin, you have to cut it and make sure it's buried deep within the muscle, the neuroma is very unlikely to form. Okay, so the risks of a neuroma forming, if you know how to manage a nerve that you cut, are low in either case, but they're slightly higher if you excise a nerve. Okay, the other risk that you can see in some cases, but it's in my hands extremely unusual, is what we call deafferentiation pain, and the very technical parlance in our field, but what some people call phantom limb pain. In other words, that nerve is still firing irrespective of where you bury it or where it's located, and yet when you touch the area that that nerve used to go to, it feels numb because there is actually no connection there, and yet the fact that that nerve end is firing inside, let's say, the muscle, is telling your brain that this area hurts. And again, that's very, very uncommon if you know how to manage a nerve, and there are ways to manage that type of pain. For example, targeted reinnervation and decide neurectomies, nerve to nowheres, which are things we've talked about in other Facebook Live sessions, and that if people want more information about, we can talk about again in future sessions. Okay. So there's another patient here that was asking about can the vagus nerve be affected in the case of occipital neuralgia stemming from dysfunction of the atlas or neck? It's a very interesting question, actually, and there have been a few papers out recently that have talked about the vagus nerve as an unappreciated or underappreciated area for the cause of a number of different disorders. However, to my knowledge, there has been no correlation between vagus nerve dysfunction and occipital neuralgia. And I think that the difference between those two is that those nerves are very anatomically distinct, even when they get near the central nervous system structures in the brain. Okay? There's another person here that says they had an occipital nerve stimulator. They've had radiofrequency ablation to many levels from C2 to C6. The headaches are worse, and then unfortunately they fell. And the question is, how long should I allow things to calm down before considering a consult for decompression or cutting? Okay, so this is actually a really great question, and a number of us that do this with some frequency have all lamented the fact that in many cases we see people who are experiencing chronic headaches as a result of some type of trauma, whether it's a fall, they were assaulted, they were in a car accident, and we know from other types of traumatic injuries, especially in the head and neck, that if you are able to get to those patients within a short window of time, and you are able to get the nerves that have been irritated or stretched to calm down acutely, then you may actually stave off the need to ever have any type of surgical intervention. So that nerve is malfunctioning. If you can reset it or decrease the inflammation of that nerve, you will be able to calm it down. Now, there's no hard and fast data on this, so this is just the opinion of several of us that are doing this with some frequency and that talk and study these types of phenomena. But it has been our general impression, I will speak for myself alone, but from what I recall from these conversations, most of us feel that if we are able to get to a patient who's experiencing acute neuralgic type symptoms in the occipital area within 6 weeks of a car accident, and we are able to do a focused steroid injection and maybe some physical therapy and massage, and that nerve calms down, you may be able to calm that nerve down to the point where that inflammation and that malfunctioning nerve doesn't become basically the new normal. And in those cases, usually within a month or two, those nerves calm down to the point where the symptoms are very, very minor and are easily managed with either over-the-counter medicines or go away. What we think, and again, no one's ever proven this scientifically, but what we think happens if you don't get to these nerves within a let's say that 6-week window, is those malfunctioning mechanisms basically take hold, and it becomes, if you will, to use common terminology that many people use these days, the new normal, and those nerves begin to malfunction on a chronic basis. And at that point in time, there are other things that also occur. For example, if you've had a whiplash injury, you may have had a little tear in the muscle where the nerves pass through, because of course that's a little defect in the muscle, and that's a weak point within that muscle, and that tear may have healed with scar tissue, and scar tissue is formed around that nerve and constricted it, and now that nerve is not gliding back and forth or up and down as you move your neck side to side from one shoulder to the next or forward or backwards. And each time that nerve is asked to glide past that muscle, it becomes kinked instead of gliding smoothly past. And once those physical mechanisms take hold, those nerves essentially become permanently malfunctioning, and that's what we feel has led to a lot of the patients that we see who've had pain for many years. I saw a woman today that I'm operating on tomorrow who's had pain for 33 years following, or 32 years following a fall at age 33. So the simple answer to the how long should I allow this to calm down before considering a consultation, I would advise going to see someone who has experience treating patients who have this type of neuralgia relatively soon. That does not mean that you need surgery, but you need to have an evaluation to see whether or not there is a specific nerve or nerves that may be irritated as a result of whatever injuries you may have had. For example, this person says they had a fall and they actually injured 3 teeth from that fall, so it sounds like it was a pretty significant fall. And if you can get those nerves to calm down in the acute setting, you may never need to have surgery. Now, obviously, the steroid injections that we're talking about may not help every single person and in every single case, but it's certainly worth trying. And if you can do anything now to stave off the need for an operation later, certainly that would be preferable to everyone. Okay. There's someone that was asking if I'm a responder to occipital blocks, would I be a candidate for this procedure? And again, I think the answer is yes. I do think that there are some patients, and they're pretty rare in my experience, especially once these injury malfunctioning mechanisms have taken hold, that can get a nerve block with steroid and their symptoms go away for, let's say, 6 months or a year. If you are one of those lucky people, then certainly getting an injection with steroids once to twice a year is a very, very reasonable management option, and you may never need surgery. But most people don't respond for that long a period of time, or don't respond significantly enough. So the pain may go from 9 to 5, and certainly that's better than a 9, but it's hardly, in most cases, sufficient when, if you inject a nerve block with a steroid, and those first few hours when the nerve is asleep, your pain is a 0. Most people would say, look, I want as close to that type of relief as I can get. Of course, if you have relief for only a few weeks, you cannot get steroid injections that frequently because they have way too many side effects when they're used at high doses like that. Okay. There's another patient that says, I've suffered for 3 years now from constant pressure and stabbing. It started as a weird pressure feeling. Then there was dizziness and balance, and they go on to list all of the modalities that they've tried. But they're wondering, is it possible that there's an artery or muscle that's compressing that nerve that's still making you feel all this pressure back there? And again, that's certainly a possibility. For example, for the greater occipital nerve, there are 6 potential compression points. Not all compression points are involved in every single patient, but we look at, and in my opinion, you must look at all 6 compression points in order to decide whether you have done a complete decompression. Because if you don't look at all 6 compression points, you may miss one, and you may only do a partial decompression. Okay. But there are any number of structures that can cause the compressive element. Okay, the first thing is obviously a spastic muscle. And if that's the case, Botox may be of benefit, at least in a temporary fashion. But obviously a muscle can pinch a nerve, and so you remove very commonly a small piece of the semispinalis muscle when you decompress the greater occipital nerve, for example. As you go down deeper toward the obliquus capitis muscle, which is compression point number 1, there's often some very thick fibrous tissue or connective tissue. Think of that as like the Tyvek envelopes, those fiber envelopes that you could put a 50-pound brick in and shake it up and down, and the envelope doesn't tear because those fibers are really strong. That's the kind of fibrous tissue we're talking about there, and those can kink those nerves as they pass around those muscles, which the greater occipital nerve does do around the obliquus capitis. That would be compression point number 1 that's described in any number of papers. And then, of course, there is the interaction of the greater occipital nerve with the occipital artery, and that artery can have any one of 3 configurations in my experience around that nerve. You can have an artery next to a nerve, but within a small space, so that there's barely enough room for that artery and that nerve to fit in that space. And as that artery is pulsating against that nerve, it's banging it. And those are the kind of people that often describe these pounding, throbbing headaches, especially when they engage in physical activities, because one of the things that happens with increased physical activities, such as running or exercise, bending over, is your heart rate and blood pressure go up, and those nerves will get pounded on even harder by those adjacent vessels, since there's nowhere for that nerve to go. Okay, it's stuck and it's just getting hit. There are arteries that wrap around nerves like an anaconda, and again, as those pulsations pass through those vessels, that nerve is being squeezed harder and harder. And I've seen cases where you have a nerve and you have an artery that's splitting it, and again, you have an artery that is banging against a nerve. So there are any number of structures, connective tissue, muscle, arteries, that can cause these nerves to have problems. And then, as we mentioned in one of our last two, I can't remember which one, sessions of Facebook Live, there was a very nice paper done by Baum and Gairon and several of the biology departments at Case Western Reserve University, and they showed that the peripheral nerves in the head and neck of patients suffering from migraines had a different ultrastructural makeup, and they showed deficiencies in some of the structures within those nerves that we feel render them susceptible to irritation by local structures. So if you have a nerve that's just barely compressed, but your nerve has these structural differences, you might be someone who suffers from occipital neuralgia, because that nerve is going to be predisposed to being irritated, as opposed to the same degree of compression in a person who doesn't have those nerve disorders, and whose nerve is therefore not nearly as irritated and therefore is relatively asymptomatic. So those are the issues there. Do I need to have a recent MRI of my cervical spine? The answer to that is no, not necessarily. You can have an MRI of your cervical spine within the last couple of years. The key really is if you had an MRI of the cervical spine 5 years ago and it showed that there was no evidence for herniated disc, fractured vertebrae, horrible arthritis that's compressing a nerve root, and nothing has changed with respect to your history in terms of additional trauma, a significant change in your symptoms, then there's no real need for a repeat MRI. I'm not necessarily big on radiating patients. MRI is not radiation, it's magnetic energy, but still it's often a very uncomfortable study. People get claustrophobic in those MRI machines. They can be very loud, and it's an uncomfortable study to have to go through. And in the overwhelming majority of cases, when the clinical history, etc., fits with, let's say, a specific peripheral nerve causing a problem, then I believe a repeat MRI is not necessary. But if your symptoms have changed, if you had an MRI 5 years ago and your neck was supposedly normal, but you had 3 car accidents since that time, an MRI probably makes a lot of sense more recently, because things may have changed. You may have findings there now after 3 car accidents that you didn't have before. There's somebody that asked, do you repair spinal stenosis? The answer is no. I am not a spine surgeon, and I'm not a neurosurgeon, so I never see the spine and I never see the brain when I do my operations, unless I'm operating with a neurosurgeon, usually to fix a big scalp defect from horrible cancer. I think that also gets to the answer to the previous question, which is if you have stenosis at the spinal cord or column, okay, that is something that in my hands will always need to be addressed first surgically, either by an orthopedic spine surgeon or neurosurgeon, because that is the root of the tree. So if you have foraminal stenosis, so narrowing of the little holes or foramina through which, let's say, the C2 nerve root goes, the C2 and C3 nerve roots become the greater, the lesser, and third occipital nerves, as well as other structures. So if the nerve root is compressed, that should always be addressed first. It may or may not actually fix the problem if there is also compression peripherally, but it's certainly something that needs to be addressed first. And that is one reason why, if there's any evidence for that type of pathology, and a patient shows up to my office and has not seen a spine surgeon, they get an evaluation by a spine surgeon before we consider any operative intervention. You can still do blocks to try and help diagnose and narrow things down, but you would I would never operate on that person until a spine surgeon has opined that there is no surgical intervention that's required for their spinal stenosis. Somebody's asking a question right here, right now. If there's ongoing pain around the ears and the jaws with occasional flares in the occipital area, is the cause easily determined for surgery? Again, it easily depends on what you mean. There are a number of reasons that you can have pain in those areas. Obviously, starting from ENT causes, you can have middle ear infections or inner ear infections. You can have benign tumors, which can be relatively large, called acoustic neuromas. So that is the type of structure or problem that can cause issues with the ears and the jaws. You can have something called neurogenic thoracic outlet syndrome. The thoracic outlet or the brachial plexus is a whole nest of nerves that come out of the neck and go to the arms and the shoulder areas. And there are a significant subset of those patients who have irritation or compression of the nerves there that can lead to jaw, specifically lower jaw pain and ear pain. You can have temporomandibular joint disorders that can cause ear pain, and of course you can have occipital symptoms, specifically the lesser occipital nerve or auriculotemporal nerve, that when irritated can cause pain in those areas. And so there are a number of diagnostic tests that you can consider to evaluate those things, from CT scans and MRIs to nerve blocks and scaling blocks in the case of a brachial plexus issue or neurogenic thoracic outlet syndrome. So would I say the cause is easily determined? Depends on what you mean by easy. It can be determined, but it requires a very specific approach to rule out each of those things in order to determine which, if any, is actually the problem. All right, and we have time for one more, and this is going to be a relatively quick question. Have you seen more bleeding and or pain control issues in redheads? And that's, I thought, an interesting question, because there is a study, or a couple of studies done actually in the dental literature, that suggests that redheaded people have a certain gene mutation or variation, I guess is the right way to say it, which renders them less tolerant of local anesthetics. All right. Now, that type of work has been repeated in other areas, non-dental studies, which have not shown that. So the simple answer to that is it's somewhat controversial, but there are some people that believe that redheaded people have a relative intolerance to nerve blocks and local anesthetics, and therefore require more opiates and have more difficult pain control issues after surgery or any sort of intervention or injections. To my knowledge, there has been no specific data that suggests that redheaded people have increased incidence of bleeding disorders and therefore would have any greater risk of transfusion requirements after surgery. I'm going to leave it at that this time. I apologize for our late start. I will say, please keep those questions coming. I would be happy to have additional Facebook Live sessions if there seems to be a lot of interest, so feel free to reach out to us on Instagram, Facebook, via email, the website, however you want to do it. And the other thing is that I have spoken to my colleague, Pamela Blake. She is one of the co-authors and very well-known, very well-established headache specialist, board-certified neurologist. She will be joining us in the next couple of weeks on Facebook Live, and I'm really excited about that because she and Rami Bernstein, from one of the Harvard hospitals, Beth Israel Deaconess, recently wrote that paper that I published, that I posted on they published it. I posted it on our Facebook pages and Instagram, talking about a new headache entity called unremitting head and neck pain, UHNP, which I think is actually a good way of describing the neuralgia type symptoms that people with nerve compression headaches have. So she'll be talking to me about that, and I think it's just so refreshing and wonderful to finally see someone within the neurology community, and a prominent person within the neurology community who can speak the neurology language, actually have a way to describe to her colleagues that the type of work that we're doing is actually of value to people. So we will have more information on that coming in the next couple weeks. Please join us for that. I think it's going to be a very informative session. And please keep any questions that you have coming. Thank you so much for joining us. Apologize for the late start. And we will catch you again on the next Facebook Live. Take care, everybody.